in regards to your comment about the different mutations, do you think that PARP inhibitor and androgen receptor pathway combinations are going to be useful at all when it comes to this, or do you think that there's some that are just going to be more effective with certain mutations? Do you have any thoughts on combining?
So we definitely know that there is synergy with the hormone agent and PARP inhibitors. We have 3 approvals of the combination also in the castrate resistant setting. The issue is that patients on those trials did not receive a second generation anti-androgen prior to receiving the PARP inhibitor. So we don't know the true benefit of the combination versus if they were given in sequence. But I think that that is a great point about the combination. And, in this Amplitude trial, it was given with abiraterone. So, and the control arm had abiraterone. So we know that the patients benefited with the addition of the PARP inhibitor in this setting. But the question of sequencing still remains because a lot of the patients on the control arm did not have access to the PARP inhibitor at the time of progression.
Mm. Um, you talked a little bit about what you were excited to see. What direction do you hope to see some of this research take in the future?
Well, I think the first step is on a level in the community and academics. It's important for all patients to get germline testing and somatic testing to know if they have any of these mutations. So that's the first step. I think as far as moving this research forward, it would be great to have more data on the overall survival in terms of getting the approval in the earlier setting. So I think until we see those results, it may be challenging to think about moving this drug in the earlier setting.
So let's talk a little bit about kidney cancer, which there was another exciting study that you saw at ASCO in regards to that. So tell me about what your experience has been and what some of your challenges have been with working with kidney cancer patients.
So, as far as kidney cancer, we know that we have the approval of adjuvant immunotherapy for 1 year for patients with resected localized kidney cancer or renal cell carcinoma that has high risk features based on the Keynote 564 trial, which gives patients adjuvant immunotherapy, pembrolizumab, for 1 year after their nephrectomy or their surgery to remove the kidney. And we had an update from that trial this past weekend at ASCO talking about the 5 year update of the data. So it continues to show a significant disease-free survival benefit and a significant overall survival benefit. I think one of the important things, there was a really interesting case-based management discussion this past weekend that talked about counseling patients on the risk benefit of the adjuvant immunotherapies. So there are different risk calculators. One that I use is called Assure, where you can plug in different features about the tumor size, the histologic features, the grade, and it can tell you what the risk of recurrence is for that patient specifically. So I think that can help as far as knowing the risk for each individual person and when counseling the true benefit of the adjuvant immunotherapy. So we know that patients with more advanced, bigger tumors, higher grade, maybe could benefit from the immunotherapy more than those patients on the trial that had smaller tumors. That being said, I have the discussion because across the subgroups there is a benefit. So I think it's really important that those patients get referred from urology to medical oncology to have the discussion on the benefit of the adjuvant immunotherapy, particularly if they have also features that are more aggressive, like sarcomatoid features and things like that.